Cardiovascular disease management is an often overlooked but critical aspect of care for people with type 1 diabetes. According to the latest research made by the scientists, cardiovascular disease is the most common cause of death in type 1 diabetes as it is in type 2 diabetes. Yet, there are no randomized clinical trial data to support cardiovascular risk interventions for people with type 1 diabetes specifically. Professional society recommendations for lipid lowering are developed primarily from trials of people with type 2 diabetes and are conflicting. Cardiovascular risk management typically receives far less attention than glucose management in type 1 diabetes office visits, especially in younger adults. Type 1 diabetes in a certain way is where type 2 diabetes was 20 years ago, in the sense that we used to be extremely glucose-centric, but we were kind of forgetting about cardiovascular risk. That has totally changed in the type 2 diabetes world. Now, with type 1 diabetes, we are realizing that while glucose control is extremely important, it is not enough. Things like strict blood pressure control and lipid control are lagging behind in type 1 diabetes, she said. One reasoning is the lack of clinical trial evidence for lipid blood pressure control, antithrombotic, and obesity interventions in type 1 diabetes. And I also think that because people with type 1 diabetes are often younger, it doesn't always click that they are at extremely high cardiovascular risk. Manrique-Acevedo said, moreover, achieving tight glycemic control in type 1 diabetes can lead to weight gain, which adversely affects cardiovascular health. If you gain more weight, you are going to be at higher risk of hypertension and other complications from excess weight gain. When we see patients with type 1 diabetes, we want A1C to be a target, but we aren't always addressing excess weight gain because it's not easy to address and there is a risk of hypoglycemia. There are many things that come into question that we don't yet have all the tools to address, she said. Asked to comment, Viral Shah, MD, Professor of Medicine and Director of Diabetes Clinical Research at the Center of Diabetes and Metabolic Diseases, Indiana University School of Medicine, Indianapolis, told Medical News, over many years, we have been focused on the A1C and the microvascular complications in type 1 diabetes, and we're not even thinking about macrovascular. Now it's time to think about it. So I would highly encourage people to start thinking about cardiovascular and neurocognitive issues, particularly in middle-aged to older groups that have not been talked about in the past. Biologically similar to type 2 but also different, Manrique-Acevedo's co-authors on the review paper were MD, Professor and Diabetes Treatment and Teaching Chair at the University of Washington School of Medicine, Seattle. Division of Endocrinology, Metabolism and Diabetes. They begin with a review of the biology of cardiovascular disease in type 1 diabetes. Many of the mechanisms are believed to be similar to those in type 2 diabetes, but there are some differences. For example, obstructive coronary heart disease appears to be less extensive in type 1 than in type 2, but vascular wall inflammation appears higher, independent of glycemic control. The review included a second box summarizing more agreed upon recommendations for A1C less than 7% if possible without increased hypoglycemia. Blood pressure control to less than 130 by 80 mmHg, or better, less than 120 by 80 mmHg, with treatment including renin-angiotensin aldosterone blockade and aspirin 75 to 162 mg as either primary prevention in patients aged more than 50 years with additional risk factors, or secondary prevention in those with established atherosclerotic cardiovascular disease. For obesity management, recommendations include caloric restriction and increased physical activity aimed at achieving 5% to 10%, weight reduction, consideration of referral to a lifestyle modification program, and consideration of a glucagon-like peptide-1 receptor agonist with shared decision-making regarding potential side effects. Bariatric surgery has also been shown effective and safe in people with type 1 diabetics and obesity. The weight loss managed and maintained with slow taper of semaglutide, personalized doses, and slow tapering of semaglutide in patients who also follow a digital weight loss program can lead to maintenance of target weight up to 6 months later, show retrospective real-world data. Lower doses were found to be just as effective as higher doses for weight loss. Slowly reducing medication while focusing on lifestyle changes using a digital program seemed to help prevent weight regain. Patients in the weight loss program used around a third, 36.1% of the suggested cumulative semaglutide dose and lost a median of 14.8%, 95% chloride, 14.3% to 15.2% of body weight by week 64. Side effects include nausea, vomiting, and stomachache, but were mild and transient.